Let's take that break. We're back in 3 minutes. We got people hanging on. Stay where you are. We're back in 3 minutes. Dr. Steve Levinsky will take your questions when we come back. This is Dr. Frank Adams on Dr. Radio, Sirius XM 110. Do not go away.
Never miss a beat of Dr. Radio with the new Sirius XM app. Streaming now included with most Sirius XM subscriptions. Go to SiriusXM.com/more.
行了，手机自由了。
Finally, some smooth
绑着呢。
years after an unsmooth year. Yacht Rock Radio has returned for the smooth, the easiest,
放上照片了，发微信了什么的。行了。
Kenny Logan, Ambrosia,
姑娘联系了。
more Yacht Rock Radio, anchoring down all summer long on Channel 70, and of course all year round on the Sirius XM app.
Wednesday on Dr. Radio at 6 a.m. East. Aspirin. Interventional cardiologist Dr. Fred Fite discusses the benefits of this over-the-counter medication for helping to prevent heart attack and stroke. Learn why dosing is important and why taking this seemingly benign pill should always be discussed with your physician. At 8 a.m. East, can chemotherapy put women with breast cancer at higher risk for developing COVID? Dr. Stephen Hodak hosts medical grand rounds and examines the latest research. That's just some of what's happening Wednesday on Sirius XM Dr. Radio.
This is an important message from the CDC about coronavirus and keeping children healthy. Watch for any signs of COVID-19 illness, such as fever, cough, or difficulty breathing. Teach and reinforce everyday preventative actions, such as washing hands. Help your child stay active for physical and mental health. Help your child stay socially connected. And watch for signs of stress or behavior changes. For the latest information from the CDC, visit coronavirus.gov. That's coronavirus.gov.
This is an important message from the CDC about coronavirus. Many people may find this time to be stressful. Taking care of yourself, your friends, and your family can help you cope. Take breaks from news, including social media. Take care of your body. Eat healthy, get exercise, and plenty of sleep. Avoid alcohol and drugs. Make time to unwind. And connect with others. Talk with people you trust about your concerns and how you're feeling. For the latest information from the CDC, go to coronavirus.gov. That's coronavirus.gov.
New channels on the Sirius XM app bring the beat. So walk to the block, hear hip-hop from back in the day. Back then, this summer through today on the spectrum of hip-hop. Or throw it back a couple decades with the smooth hits of 90s R&B jams. Tap in now. New channels, more choices. Only on the Sirius XM app.
Coronavirus. What you need to know now.
All these recommendations have been made to bring those numbers down. Working here, staying 6 feet apart, and wearing masks when we're around people we don't know. Not getting into crowds, limiting our travel, and making sure that when we're in an inside space that is well ventilated. All of those things are working, and they work together to make all of us safe.
Hear the latest updates about COVID-19 on Sirius XM Dr. Radio.
Get facts, not fear. Dr. Radio brings you everything you need to know about the coronavirus crisis. Sirius XM 110.
就进咱们走了。
我现在还得走112迈。
Dr. Frank Adams, we're back on Dr. Radio, Sirius XM 110. It's a pulmonology show, which means I'm a lung specialist on the faculty here at NYU Langone Health, the greatest collaboration between NYU Langone and Sirius XM. I promised I'd go right to the callers, and Dr. Steve Levinsky is with us. I'll tell you more about him in just a moment, but we have some people that hang on for a while. So I want to go to AJ first. AJ is in Atlanta, Georgia. Good morning, AJ.
Hi, good morning. I was wondering if any of you have seen any evidence of pulmonary arterial hypertension. I've seen some case reports, but seems to be in the post-mortem setting. Just providing some quick background. Can you hear me?
Wait, you just kind of broke up a moment ago, AJ, but I would imagine Dr. Levinsky would have more experience having been the director of our NYU Langone Brooklyn ICU, and he mentioned embolic disease. And Steve, any data on that in terms of complicating COVID-19?
Okay, I think the question was about pulmonary arterial hypertension. And the answer is that there's not enough data out there to really comment. Large series that include echocardiograms or other imaging of the right heart and pulmonary vessels and follow-up. That said, the propensity of COVID-19 to be associated with large and small clots seems to be significant, seems to be more significant than other diseases. So there are some studies that have been published that are interesting and compare imaging and post-mortem evaluation of patients who had influenza with those who had COVID, and find that the patients with COVID tended to have a more involved pulmonary vascular tree with viral damage and thrombosis. So I don't think, from what I know of our survivorship cohort, that we're seeing a large number of patients with that problem, pulmonary hypertension complicating COVID infection. But our follow-up protocol does include echoes and for research on MRIs of the heart. So it's a good question, and we'll probably learn more about it this year.
Okay, AJ, thanks for calling in. It's a great question. As Dr. Levinsky says, there's more to come on that area. Let me take a moment to tell people out there just joining us that Steve Levinsky is with us, clinical associate professor at the NYU Grossman School of Medicine, associate director for adult Ecmo. We'll talk about that in a moment. Medical director of respiratory care at Tisch Hospital. He's our expert pulmonologist, taking all your calls and questions. We've been focusing on COVID-19 and focusing on vaccinating the part of the population that has been hesitating. And there's been a report of a possible mild form of myocarditis in some young people receiving the mRNA vaccine. Very, very few cases of a mild nature. So we have a caller on the line with a question about it. So let's go to John. John's in Massachusetts. Good morning, John.
Yeah, that was specifically my first question. So is there any more updates on that? Supposedly it's like a few days after the second dose.
Right. Steve, I haven't seen anything more beyond that initial report, as John was alluding to, that very few cases, mild myocarditis, usually a couple of days after the second dose, but still, the frequency is not above what is considered the normal number of cases, as far as we can tell. So that most people are saying there won't even be a pause in the use of the vaccine. I don't know, Steve, have you heard anything else?
No, I think we're waiting for high-quality information on this. Millions of people in the United States have been vaccinated, and we're hearing about case report levels of this issue. It likely is not indicating a major new problem, but we'll see.
Okay, all right, John. Thanks for bringing it up here on Dr. Radio. This is Dr. Frank Adams and Dr. Steve Levinsky. We have Steve for about 15 more minutes, so. You give the toll-free number to reach us. We take all your calls about pulmonary disease, but again, we're focusing on COVID-19. But whatever on your mind in terms of lung disease, call us at 1-877-698-3627. We're hoping those who are hesitating to be vaccinated will call in. That's also 1-877. You can email us. SiriusXM.com. Get your email right on the air. You can even tweet us at NYU Docs. And a little bit more general pulmonary question is coming from Tom. And Tom is in Florida. Good morning, Tom.
Hello, gentlemen. Thank you very much for providing this wonderful service for our community. I had a question. My partner, he's 52 years old. He, over the last 3 years, he's gotten pretty severe bronchitis during the flu season. He's always called negative for flu, and this year he got a very severe one where he's hospitalized briefly, and I was put on steroids in December, and he also got it again about a month ago. Both times he was negative for the flu and for COVID. And now he's a long-term marijuana smoker, 30 plus years. He is very stubborn. He insists that marijuana has nothing to do with COPD or anything like that. And now he's even more convinced that he's safe. Can you give me the correlation on COPD and marijuana and that kind of thing?
Okay, so some great
frequent, bronchitis.
Yeah, great questions that we get a lot in the office. Use of marijuana and then also electronic devices, vaping, and are they bad for the lungs? And lots of research piling up in both areas, but sometimes conclusions are still lacking. But Steve, what do you think? Could this be contributing to this fellow's recurring, he's been hospitalized twice?
Well, the history of marijuana smoking, we didn't get the type of device, and vaping is sort of like, like out of the frying pan and the fire, maybe, for me. I think that someone with a history of lung disease, we recommend against, any of those practices. Vaping certainly, that was the respiratory epidemic right before COVID, that it can be associated with severe and less severe pulmonary conditions, disease, and lung injury. So vaping certainly is not recommended. The amount of data for tobacco smoking, greatly, this is much more than there is for marijuana smoking, but in a person especially with symptoms of bronchitis, and as we heard, we would recommend against, really smoking at all.
Right. As I see my own patient population and as legalization of marijuana increases, with people coming in who are more open about their use, it's clear those who are very heavily using marijuana tend, in my own experience, and I've seen other reports, to get more coughing, more sputum production, more congestion, which I think could contribute to developing bronchitis. So we don't know about Tom's partner in terms of consumption, but Tom, I think it's, as Dr. Linsky said, this definitely could be contributing to his problem. It could be one reason he's had such severe bouts of bronchitis and needs steroid hospitalization. And then the electronic device, whatever device he's using, certainly also now implicated in working with bronchitis, asthma, especially in young people. So we're both standing against the use of both types of inhalation. Tom, thanks so much for raising that concern.
Post-obstructive pneumonitis, severe hypoxia, and they're going to host it tomorrow. She's also going to have a smoking modality. She'll have start radiation and chemotherapy with topotecan. Last year she had carboplatin and topotecan. And I'm wondering, with shrinkage of the tumor, am I going to have to worry about dentimigration, and what post-surgical issues or challenges will I have to face? And if she really has some energetic spread of my lower node, so we're going to increase tendencies to right upper and middle node, diffuse them also, and these symptoms that is greatly appreciated.
刚才挺吓人，都偏到了。
scans and information. We can't talk specifically. I know Dr. Vincent was very responsible for this, but not really an intervention. So Steve, I'm not sure how much we can tell them.
Yeah, well, I think that as we heard, that it sounds like it's a complicated case. And the role for airway stenting, often is somewhat a complicated topic, especially in cases where unfortunately there may be spread beyond just one area where the airways narrow. Generally, the point of putting in the stent is to relieve symptoms and prevent or treat post-obstructive pneumonia to allow for other treatments to work, to treat the tumor burden. As was mentioned, there can be issues with stent migration and with mucus impaction and other issues that, whoever puts the stent, surgeon or interventional pulmonologist, will usually give a discussion about the monitoring for that, and then other airway clearance treatments, nebulizers that are sometimes given along with it. So airway stenting, can be offered in cases that, similar to what we heard, it's usually given in the setting of a multidisciplinary approach to treating the tumor and to treating symptoms associated with the tumor. The effects can be variable.
Donna, we appreciate your concern, of course, and we hope things will go smoothly. And it sounds like you assembled the team that you need to put this together, and hopefully the outcome will be very good. Thank you so much for calling us. A little more than 5 minutes without Steve Levinsky. Again, toll-free number 1-877-698-3627. We've had some great response. We appreciate that. Our email is docs@SiriusXM.com. Tweet us at NYU Docs. I was hoping, Steve, would have enough time, and maybe we'd have just barely enough time for you to just kind of introduce Ecmo to the listeners, and what does it mean, and has the pandemic actually brought Ecmo, it's been around for a long time, but it's brought it to the forefront, which I think is a good thing. So talk a little bit about that.
Sure. So Ecmo, or ECMO, it's extracorporeal membrane oxygenation. And that's a life support modality that uses cardiopulmonary bypass technology, so large intravenous and sometimes intraarterial catheters, a blood pump, and an artificial membrane lung to support patients with lung failure or heart and lung failure. So in COVID-19 and other forms of acute respiratory distress syndrome, the configuration is used to provide basically an extra artificial temporary lung to support the patient while their injured lung recovers. We have data that suggests that some patients may benefit from this, and that it's probably a subgroup of patients with very severe respiratory impairment, absence of other problems, other organ failures, and if given within a certain amount of time and within certain gas exchange parameters, degree of lung injury. ECMO as a treatment has evolved over time from when it was, decades ago, a very large, bulky, dangerous device towards it's a lot more compact and miniaturized. And that every time there's a respiratory viral pandemic, like the H1N1 pandemic in 2009, there's sort of a need for this technology, or sort of get some more use. So we have found good results in a subgroup of patients with severe COVID who have received the treatment, and the use around the world has increased in the setting of the COVID pandemic. It's a treatment that we think can benefit some patients, but it's very intensive. Requires can only really be given in specialized centers, and can produce some of its own problems. It's a very hematologically active device. It's large. Basically, the person's whole blood volume goes through an artificial device. So you can imagine COVID already causes thrombosis. This can compound that. Infectious complications are also very common. So it's in the sort of list of things that may be discussed in an ICU admission or for certain patients coming to the ICU, like mechanical ventilation, like vasopressors for the blood pressure, it's a device that may come up.
Ancient history that I can remember as a medical student. People setting it up, and it took up the whole room. It was huge, and it's changed a lot. Steve, what's the longest you've had a patient on ECMO, and is there a time limit? Right. Well, the longest NYU has had is many months, several months. And really, the time limit is determined by the patient. COVID can be protracted, so a lot of the treatment involves patients and waiting for the patient to recover. So we expect, the median duration in our cohort was a month of ECMO treatment. So we anticipate, many weeks of treatment, and some patients actually require months of treatment. One medical and sometimes ethical issue is, well, what if the patient doesn't recover or has other problems happen, in that they're not a candidate for, say, a lung transplant? Should the treatment be continued indefinitely? So it's an issue that we sometimes have to deal with in the ICUs, and can like mechanical ventilation, it's there. It's a bridge to recovery, but can sometimes cause other issues that we need to address. All right, we're under 3 minutes. I want to try to get one more call in. Let's go to Elijah in Houston, Texas. Good morning, Elijah.
Hello.
Hi, you're on Dr. Radio.
Hi, I was calling in regards to, you said that there's antibiotics that are stored in your body, and after a certain time limit, those antibiotics kind of go into the system, so that if the virus is ever reinserted, and if it ever reoccurred, the antibiotics could make more of themselves to fight off the virus. So if a person that's COVID and gets the vaccine, does it just strengthen the antibiotics, or does it,
Okay, so I think the caller is, first it's antibodies and not antibiotics, but Steve, you mentioned earlier that there were different responses from natural infection versus vaccination. And I think the goal is trying to get to distinguish between the two.
Yeah. Well, this sort of gets back to a point of what we have been discussing, that the antibody response to COVID infection may somewhat differ from the antibody response to each of the vaccines. And if you look at the different vaccines, the 2 mRNA vaccines are a bit different than the adenovirus vector vaccine in terms of their protective ability. And so the type of response that occurs is one question, and then how long does it last is another question. And I think that second one is as more people are vaccinated and have been infected and have some degree of natural immunity, is going to be a serious question going forward. But we know that the 2 mRNA vaccines require 2 shots to really get full immunity, and there may be, as data emerges, there may be recommendations around boosters in certain populations. So what we know is that the vaccines, prevent symptomatic COVID infection in, basically 95, the 2 mRNA platform vaccines prevent symptomatic COVID illness in about 95% of patients. And that's very good.
Steve, they're playing the music. So vaccine, please go ahead and be vaccinated. Steve Levitsky, thank you so much for being with us. Going to get you back as soon as we can. And thank you, Scott Ewing, Keith King, for all the work you do. We'll be back here next week.
Sirius XM's Business Radio presents 2 new shows. Series A with Keith Raboy and The Beer Hour with Jonathan Wingfield. Tuesdays, Keith Raboy is joined by top CEOs in leaders in the tech and service industry. This week, Tony Xu, CEO of DoorDash. Thursdays, Jonathan Wakefield explores craft beer and pop culture. This week, Tio Hunter from Crown & Hobbs. And Aaron Brooks, executive chef at Four Seasons Miami. Listen on Channel 132 or anytime on the SiriusXM app.
SiriusXM and NYU Langone Health present a new podcast, Vital Signs, where medicine is made personal.
I basically died 7 times.
I called my husband and I said, it's cancer.
Featuring some of NYU's world-class physicians telling their own extraordinary stories.
This was the first time I was really scared.
He jumped back and said, oh my God, he opened his eyes.
Vital Signs, a new podcast from SiriusXM and NYU Langone Health. Subscribe now on the all-new SiriusXM app. This is an important message from the CDC on managing stress. Everyone reacts differently to stressful situations. To better handle your stress levels, take breaks from watching, reading, or listening to upsetting news sources. Take care of your body with deep breathing, good nutrition, regular exercise, and healthy sleep. Talk to your doctor about how you feel and if other therapies might be right for you.
Is an important message from the CDC on managing stress. Common signs of stress and anxiety include feelings of fear, anger, sadness, numbness, or frustration. Also, changes in appetite or energy levels, as well as difficulty concentrating or sleeping, may be signs of emotional distress. These feelings are very real, and treatments can help. Reach out to your doctor to learn more about the confidential resources and therapies available to help.
It's not just a race, it's an American tradition. The Indianapolis 500 is on SiriusXM. You'll see the checkerboard power Indianapolis 500 who will kiss the bricks this year. Find out Sunday at 11 Eastern when SiriusXM brings you the 105th running of the Indianapolis 500. Lap-by-lap coverage is on NBC Sports Audio Channel 211 with extended coverage on IndyCar Nation Channel 205 and the SiriusXM app free for most subscribers.
The information and opinions expressed on Dr. Radio are intended to address the specific questions asked or situations described on the program and are not designed to constitute advice or recommendations as to any disease, ailment, or physical condition. You should not act or rely upon any information contained in this broadcast without seeking the advice of your personal physician. If you have any questions about the information or opinions expressed during this broadcast, please contact your doctor. Thanks for listening to Dr. Radio.
Recognizing the efforts of the healthcare workers on the front line of this coronavirus crisis, this is Dr. Radio, SiriusXM 110.
This is SiriusXM Dr. Radio.
From the heart of the NYU Langone Medical Center, this is Plastic Surgery.
Welcome to the Plastic Surgery Show. I'm Mel McCarthy, your host for today, and we are live from our studio at the NYU Langone Medical Center. You are listening to Dr. Radio on SiriusXM Channel 110. Our phone number is 1-877-NYU-DOCS. That's 877-698-3627. And we are lucky enough to have Dr. Ashley Amalfi, a board-certified plastic surgeon from Rochester, upstate New York. Ashley,
这个收获的是什么？
I'm there, Nolan. Thanks for having me. This is so exciting.
All right. We're very, very happy to have you. So what's doing? How are things up there in upstate New York?
It's beautiful. I mean, this is the best time of year in New York, right? We live for summer and warm weather, and you know the world is opening up a little bit, and plastic surgery has never been busier. So it's a pretty amazing time to do what we do.
Well, what was your experience with the pandemic? I mean, I know we were been busy kind of the whole time once we were able to reopen. Was that your experience also?
Absolutely. I mean, the minute we opened those doors, we had surgery booked, because even when the operating rooms were closed, we were doing consults virtually, so our schedules were full. And for patients, it was just a time of opportunity because they weren't working or they were working virtually, and recovery and time off from work was no longer a variable. So everyone who had been thinking about doing something was like, oh my gosh, this is the perfect time, I have to get in. And and it hasn't stopped. And I don't know if you guys have seen, and so many people are like, well, I'm in the office, but if I need to be remote for a week or two for recovery, that's no problem. And so I think that this might be the new normal, Nolan, where people have this option to virtually, to remote in to work, and so that when they wanted to.
It was a little weird because, like, this time last year, there were many more homeless on the street, and like today I saw like not a single homeless person, and I think a lot of it has to do with, and you would think because the weather's warmer they would be out, but a lot of it has to do that the shelters are probably more accommodating, just like you don't have to wear a mask to do this and don't have to wear a mask. If you're vaccinated, you can probably go in a shelter without a mask, and they're not strict, they're just, it just seemed much more normal today.
The New York that you're used to. It's the same way here. I'm upstate, so it's very much suburban, but I'm sitting up in my home office now, and there's people running and riding bicycles, and the kids are playing in the yard, and no one's wearing masks, and very much a lot of the city of Rochester here has been vaccinated, so it's nice to see people kind of getting together and doing things. Same with our family, being able to do, sporting events with the kids, and, we're back at baseball and gymnastics, and it just feels like all those little tiny things that we were missing are sort of a small return to normalcy for us.
So anyway, getting back to plastic surgery, so what kind of plastic surgery do you do most, Ashley?
So my practice is almost exclusively cosmetic surgery. I do a little bit of breast reconstruction, but that's what's been 10% of my practice, and mostly breast and body surgery. So I do a lot of breast augmentation, mommy makeover surgery, liposuction, body contouring after massive weight loss, and then a lot of revision breast surgery. So patients who've had multiple breast surgeries or unhappy, have sort of difficult problems to solve, and are looking for final surgery to get them where they want to be.
And has any one particular area increased more, let's say, during COVID than another area? Like, are more people having mommy makeovers or breast augmentations or liposuction? I know people gain weight with COVID. There's still a lot sitting around eating.
Combination procedures because of the recovery. I think that they're thinking, instead of spacing these surgeries out, let's put them together. I'm definitely adding on a lot of liposuction for patients. So, whether they want a breast surgery or a tummy tuck, almost every patient here we're adding on a liposuction area. It's kind of a different attitude of the patient. It's kind of like, a focus on themselves, a focus on, doing whatever is important to them to feel their best. And I think COVID has caused kind of that change in patients just saying, I want this and I want to feel like this about myself, and so I'm going to pull the trigger and do it. And so definitely a lot of liposuction. I also do a lot of fat transfer to the breast for just more of a natural breast augmentation. And people are, they come back to that. They love the way that looks. They love that there's no downtime, and they're coming back for multiple rounds of fat grafting.
So you're doing a lot of fat transfer for breast augmentation.
Yes, exactly. And it's the same population, really. It's patients who have this little problem area. They want to get rid of some fat, and maybe they've had kids. They've lost a little bit of volume after breastfeeding, and that fat just adds a little bit of boost. It's nowhere near what a breast implant can do. And I tell them it'll probably fill out their cup size, or take them to a small cup size of the neck size, but it's not going to increase multiple cup sizes like an implant. But they love it. They love that round upper pole that they lose after they have kids and they breastfeed, and they come back for more. They love the way it looks, and they're like, hey, you did my inner thighs, those also look great. Now let's do my outer thighs and take the fat from there and put it in my breast for a second round. So there's even patients who we've done multiple rounds on since COVID. So that's been a really big and popular procedure in my practice.
Our phone number, 1-877-NYU-DOCS. It's 877-698-3627. We'll take your phone calls about anything in aesthetic surgery, but particularly breast body contouring. Yeah, I mean, I don't do that much. I mean, I do actually a lot of fat transfer of the breast, but I do it more on reconstructive patients to kind of even things out and, you know, blend in implants or flaps, you know, volume or edge artifacts or things like that. But I haven't done that much in the breast augmentation, but, you know, I kind of think I should in some patients. You know, to me, it'd be more like kind of blend in the implant a little bit better and things like that, you know, more as an adjunct than... I did try it at one point, but I found I just didn't seem to get like enough projection. And so,
it's a different operation, and I think the patients who come for it are different. You know, I don't think that everyone who is thinking that they want a breast augmentation is a candidate for it, because it's definitely a different expectation and a different result. But for that patient who just wants to be natural, but just wants a little boost to what she has, I think in those realistic patients, it definitely achieves that goal. And I saw how good it worked in reconstruction, because before this, when I was at the university, I was doing a lot of reconstructive surgery and doing a lot of fat grafting, and I loved it. I mean, it was predictable, it was reliable, it could obscure the edge of the implant or give more cleavage or upper full coverage, and so I kind of thought, if it's working this well in these thin flaps, then I think, you know, if I have more volume to inject, I think it's a great tool for the right patient.
Now, like, how much fat do you typically inject in each breast when you're doing like the fat injections?
So usually a few hundred cc's, but it depends on the patient. I mean, if the patient has a lot of really healthy fat to transfer, then, you know, 400.
So that's a pretty good amount. That's a pretty
Yeah, it's pretty significant, and I'm truly not injecting into the gland itself. I'm injecting sometimes right into the pectoralis. I think the blood supply of that is fantastic, and it kind of builds the base or the footprint of the breast, and then I'm going between the pec and the gland, and then in the subcutaneous plane. So I'm not just going right into the breast tissue, but, you know, in some patients, I think with a discussion of what calcified fat could look like and possibly needing more breast imaging, I think that that's not unreasonable as well.
No,
so you can get a lot in there.
Oh, no, you can. Did you do anything like the Brava or anything, you know, like to prep the breast for that, or no? I mean, that's kind of not available.
You know,
it's not available anyway.
Yeah, it's difficult, and, you know, I have used it in...
Having to go to the emergency room. Get the latest updates from Dr. Radio around the clock on Sirius XM Channel 110.
Bringing you the information you need to stay safe and healthy during the coronavirus outbreak. Sirius XM Dr. Radio.
We are live from our studio at NYU Langone Medical Center in Bright Spring. Not so hot, and not so warm. It's actually pretty nice. In New York City, our guest today is Dr. Ashley Amalfi, board-certified plastic surgeon from Rochester, New York. And our topic is aesthetic surgery with an emphasis on breast and body. Ashley, you back?
I'm here.
All righty. So, goes fast, right? I mean, it's all of a sudden have 30 minutes done before you know it.
Yeah. This is, I mean, everyone's got really exciting, great topics and good questions, and, you know, we could spend hours talking about each one of these, right? I mean, we do.
You could do a whole show. You could literally do a whole show on every topic. We're going to move on to Linda from Tennessee. Linda, you're on the Plastic Surgery Show.
Hi. I live in the western part of Tennessee. I'm not far from Jackson, Tennessee, and Memphis, Tennessee.
All right.
I'm wanting to have mine. It's I don't know if it's called a lower lid, but I have these bags under my eyes, sort of thing.
I'm sure there's somebody who does it. You just want to make sure, again, you go to a board-certified plastic surgeon certified by the American Board of Plastic Surgery. So that's kind of a critical thing. But, you know, how old are you, Linda? Yeah, I mean, you know, it's bags under the eyelids are, you know, very common, and you know how much or how little people have. It's not about like what your weight is or anything like that. You know, and thin people get them, and heavy-set people get them, and it's sort of a function of how your eyes were built. And there's really like, I consider it sort of two components. There's the fat bulging out, but there's also some ligaments, you know, at the bottom of the eyelid. It creates what's called a tear trough deformity, you know, which is like kind of like a crease under your eyelid. Do you have that? I would imagine you do.
Yeah.
And so, you know, the surgery, again, we have to look at you. We're on the radio. There's also skin that sometimes has to come out, but skin is probably the least important component of this, the lower eyelids. And, you know, what we usually do is go inside the eyelid and it's what's called a transconjunctival incision, so you don't even see it. And then we'll take out some fat and we'll release those ligaments that's creating that tear trough. And occasionally we'll even fat graft in that area as well, though I have to say I'm less a believer in that, and I find it hard to believe that the fat actually stays and things like that. I think releasing the ligament, taking out some fat, and then if you need some skin out, I take the skin out to a separate incision. What we do, it's under sedation in the office, you go home and say, it's a pretty good bang for your buck procedure. At 61, you probably, you know, when I look at a patient, I look at the whole picture. I would look at your face too. I don't know if you want to dive into that, but at 61, there's no doubt that your face is going to have some aging and some things, you know, it's like, if you're looking at the lower eyes, you want to look at the upper eyes for sure, because we're going to go to the lower eyes, you know, there's a good chance you could benefit from a little bit of upper eyelid surgery. And the face is a much bigger deal, but I kind of like to sort of lay it all out for the patient. I hate for them to have like the lower eyelids done and still feel like they don't look as young as they want to look. So
yeah, and it's just mainly because I just look, every time I see a picture of myself, I just look so tired.
I mean, it's a really good operation. It's a really good operation. I hate to admit it because I'm around your age, and so a lot of my patients, you know, the younger ones who I did the breast augmentations and they were, you know, other stuff on, they got a little older. So I do a lot of breast reconstruction, so some of those patients, you know, want to do something for themselves. So it's a very common operation for us to do, and the results are actually excellent, you know, and other than being a little black and blue and beat up. I assume your eyes are okay, you don't have problems with your eyes or issues like that?
No, they're fine. They're fine. I know that it depends on where you are, where you have it done and all, but I was wondering about how expensive this is.
You know, it depends really on your part of the country. I mean, it's not going to be, you know, cheap, but the prices can vary a lot, you know, and down in, you know, Western Tennessee, I can promise you it's going to be a lot less expensive than in New York City, you know, where everything's expensive. Ashley, any thoughts?
No, I mean, I was going to say, Linda, this is going to be one of those surgeries where you're going to look in the mirror and you're just going to be so happy you did it, and the people around you are going to think that you look like a greater version of yourself. You look refreshed and well rested. But, you know, I think some people are worried about plastic surgery making them look weird or look different, and you won't. You know, this is a surgery that's going to make you just look like a rested, rejuvenated version of yourself. And so it's a surgery that people are just super happy after. And as long as you're going to the right place, you know, you need a board-certified plastic surgeon, then, you know, you're going to have a great result.
No, I agree. I mean, I think it's you know, and it's a good start, you know, it's something you can do. And you know, we do this, believe it or not, in people in their 20s and 30s, because they just have like a weak orbital septum, which holds the fat in. It's like a congenital thing almost, and you know, it makes them look much older than they really should look. And so it's something that, you know, it's age, but it's also anatomy. You know,
So, and on their age is still 18 years.
What's that?
Yeah, I've had this a long time, probably 16 years.
Yeah, no.
I don't know why I'm just now deciding I want to do something about it, but I'm just, you know, just ready to do something.
Yeah, it's not surprising.
You're ready.
You're ready to go. It doesn't matter the age. I mean, it's something that you're going to like. I think Dr. Malfi's got it spot on. I mean, once you do it, the only thing you're going to say to yourself, why did I wait, 15 years to do this? And the other thing nice about this is it lasts a long time. Like, unlike a facelift, which kind of starts to loosen up, like I always say, your face starts aging the minute you get to the recovery room. Like, this eyelid thing is more anatomic, and you probably will never need another surgery, whereas a facelift may last 8 to 10 years. Like, the eyelids can sometimes last forever or much longer.
They're also very genetic. Like, when patients complain, especially the younger patients that we see about, that deep groove or that bulge that they have with the bags that they fall under their eyelids. It's not common for them to say, oh, my mom had this, or my dad's eyes look just like this. And so, if you kind of look at the people around you, it sort of gives you a good idea of, if you don't do anything, exactly how your genetic makeup is going to age in the coming years.
All right, Linda, thanks so much for calling. We beat that topic pretty much to death. I think go get your eyes done, Linda. That's an order, all right? Find somebody there, and you can get a few opinions, so you can kind of get some competitive prices. But make sure they're certified by the American Board of Plastic Surgery. And thanks for calling. We're going to move on to Val from Washington, D.C. Val, you're on the Plastic Surgery Show.
Hi, thanks for having me. I actually have a couple questions.
All right, we're here for hopefully we can give you a couple answers, You may stump us. We don't have every answer to everything.
Well, thank you. I was looking into getting eye surgery, the upper and lower, and the board-certified surgeon that I saw mentioned that they would be doing it in the office. So I was wondering, is it okay to have a surgery in the office, or should you go to a doctor that actually does it at a hospital? This is probably one of those things that you can do in the office. It does depend on how involved your lower eyelid surgery is, because that one can be a little bit more involved than the upper eyelid. But this is very much, a very quick in and out procedure with just some numbing medicine. There's so many great surgeries that we can do just in the office setting. You want to make sure that, they have, they're board certified, if they're actually doing it in a surgery center, that it's a licensed facility. But as long as, all the credentials add up, this is definitely a less invasive procedure and something that's very reasonable to do in an office setting.
Yeah, it's totally normal, and that's how I think it would be unusual to do it at home. Yeah, unless somebody was sick or had some sort of problem or something, or older. And I think, you could do this in the office almost always.
Okay, good. I didn't know if there was maybe a chance for anything to happen that you should be in the hospital, or no, it's a pretty safe procedure to have in the office. It just seems odd to say you're going to have surgery in our office. But I'm glad to hear that it's perfectly fine. The other question I had is, should you maybe do something like hyperbaric oxygen treatment after surgery to accelerate the healing process?
Have you heard of anybody doing that, Ashley? I mean, I've heard people getting it when they've had a complication, but not for the normal healing.
Yeah. I mean, if you have had surgery previously and had, terrible healing, and there was something wrong, medically, that they thought you needed to augment your healing, but No. Usually we only use hyperbaric oxygen when there's something that we're very, very concerned about. And so it's treating a problem, not really preventing it. Thank you both so much.
Okay, I do want to say one thing about the office. I just want to get back to this. We want to make sure that the office is like an actually certified office. And that's one thing. It could be certified. Now, to be a member, that's another thing you can do. To be a member of either the American Society of Plastic Surgeons or what's called the Aesthetic Society, or the American Society for Aesthetic Plastic Surgery, now kind of just shortened to the Aesthetic Society, you have to operate as a certified owner. They're going to, every year when you renew your membership to these things, they're going to ask you that question. But it's important to know that because there's a certain level of safety. So, I think that, and for our listeners out there, I'm sure, Ashley, your office owner is certified.
Yeah, we're AAA certified. I mean, so these are regulated bodies they're almost like mini hospitals. So even though we're not a hospital, but we're a freestanding ambulatory surgery center, which is actually within our office, there's very, very strict guidelines, and that's there for your safety. So you definitely want to ask about that, and truly, as part of your consultation, that's something that should be explained to you when they're telling you about, where your surgery is going to take place. That they should credential exactly what that means, and that's sort of like a badge of trust to understand that, okay, everything's being done. This is a safe space, and if there is an emergency, everything is ready here, and there are systems in place to take care of me should there be any issue.
Yeah, so it's very important to ask, to make sure that ours is certified by something called Quad A, and there's also the Joint Commission or whatever it is, but it doesn't matter really which one. It just matters that it's certified. They all kind of are looking for the same stuff.
Okay, great. Thank you so much.
All right, Val, thanks a lot. We're going to move on to Madeline.
走这两个花钱的景点儿够咱俩住2天店的。我说那个走这俩景点儿啊，昨天走这俩景点儿，上午一个，下午一个，够咱俩住2天店的钱啊。住2天店的。住2天酒店的。一个60，一个50，54，55。
They said, that could not be safe, but that they say about their product is they will perhaps help with the replacement and so on. But they asked me about a score. They said, do you know what the doctor gave you a Baker score? And what exactly is that?
Do you want to go through that, Ashley? The Baker?
Sure. Yeah, so that's kind of doctor language, but that's how we talk about how thick that capsule is. So whenever you put a foreign body, into the body, be it a breast implant or, anything else, your body reacts to that and forms a little barrier around it or some scar tissue, and that's called a capsule. And that's normal. That's just a normal biologic response. But in some people, that scar that forms gets thicker, and it can become because of a small infection that was in there or other, variable things, or sometimes it just happens. And depending on how thick that scar tissue is, those are the different Baker classifications. So we consider grade 1 a nice soft breast. Grade 2 is when, everything looks great, but as a doctor, we kind of feel it, and you can tell that one of the breast implants feels just a little bit more firm, or that scar tissue around it is a little bit firmer. Grade 3 is when it starts to look different, so, you can Google all those crazy pictures of Hollywood actresses who have breast implants that look like, your implant should not look like a coconut. If it looks like a hard round coconut, then that's probably starting to be a grade 3. And then a grade 4 is when we say it's actually painful. So when that capsule around the implant is so hard that not only does it look abnormal, but to the patient it's almost cold and very uncomfortable.
When it first first happened, it was quite unpleasant, painful, but I said, I didn't know what all that was about. So I said, well, let me just roll up alone. The doctor said, whatever you want it taken out, you can. If you don't, just let me know. So I was thinking, I felt over time it did get better, but I can't touch it, and I feel a protruding area on one side.
Have you had imaging? Like, do you know if your silicone implants have ruptured? Because sometimes that capsule forms because the implant itself is ruptured. Have you had an MRI or an ultrasound of your breast?
Last year I had ultrasound. I just got my, what do you call it when they squeeze them? Mammogram. I'm done. And every time I go, they said they're in place pretty good. So that is, comforting. Considering what we go through to get the image through the mammogram.
Yeah. Mammogram's not the best test to look at breast implants. It's the best test to look at the actual breast tissue. But, really the FDA recommendations for silicone implants these days are to get an ultrasound. So, of your breast. So that would be even more reason to get an ultrasound. Yeah, I think that gives you some good information, because then you know if you're dealing with a ruptured implant or just an implant that has that thick uncomfortable scar tissue around it.
Yeah, I do ultrasound in the office. We started doing it, I guess it was a little while ago. It was before COVID. Kind of everything in our life is either before or after COVID. So I started before COVID, so I guess it was, but it wasn't that much before, maybe like the November before COVID, so a year and a half. And it's pretty good,
Yeah.
If you do it or not, but it's like...
We talked about getting them, like the butterfly. What do you use? And you just hook it up to your phone?
We use, what's it called? It's like a handheld. It's really nice. It's just handheld. You see the image on an iPad. It's like on a little stand.
Yeah.
I'm just totally blanking on the company, but it's really nice. It's just easy to do, and I've done so many of them that I can pretty much tell. It's doing it with my medical assistant, and we can just look at it. We're on she can just tell herself, just see, the nice surface of the implant just falling around. You can see what's broken or cracked or stuff going outside the implant. So it's a pretty nice thing. It's not that expensive. It was like $5 or $6. So it's pretty.
我跟那个之前尿混尿下次真没有厕所。那可毁了。那一边尿什么想法都没有的。那你要补的。那点身体不好，没有厕所啊。
都是因为那个会开。疫情事儿嘛，就借由这广大给just get an ultrasound. So it's not like an onerous thing. It's like every other year thing. I just get an ultrasound. And obviously if they have any changes or symptoms or anything happens, then they just come in and just get an ultrasound. It's really good for the patients because they really feel comfortable.
Checking it out.
Yeah, they just feel comfortable about the whole thing. They feel comfortable. They feel like they, and we do it. There's no charge. It's and we do benefit because we do find ruptured implants, and we're right. It's not like there's not a return, one case basically. But it is, I think, it's for a patient satisfier. It kind of takes something nebulous, like how I know my implants ruptured, to make some much more much more definite. And if I'm not sure, I'm going to.
Yeah, exactly. And sometimes they're wrong, but having that imaging for peace of mind is great. Yeah, we definitely talked about getting one of those for the practice and actually maybe sharing it down with the OR for some blocks. So I should circle that back because I think that would be really nice to add.
We have in the office OR, it's on the side, which is much more expensive. The tap blocks and stuff like that.
Yeah.
But this is easier.
Yeah.
Yeah, get it. We give this course at meetings. Weren't you there too for
Yeah, I did. I moderated that session with you, and I was all gung ho, and I kind of forgot about it. I haven't been bugging the team.
You moderated it. You still didn't get there. I'm still trying to figure out.
I kind of forgot about it because of COVID, I think.
I just started doing it. Let me see what's that. I'm trying to. Clarius. It's Clarius.
Oh, yeah. That's the one a lot of people have, Clarius. Yeah.
Clarius. Very good. Very nice. Anyway, Virginia's still there?
Yes, I am. I just want to add one more thing, just for info, because that was an experience when I got my implants, and if I do get them removed, I want to, get them removed and get clarity, because I have silicone.
That's fine.
Smaller. But what I didn't realize until I got the contractor called the company, that, which I don't remember my position telling me, but I had those the implants themselves are under warranty, which turns out to be a very good thing and very, very good information.
Right now, they are warranted. I do believe it's for 10 years, but I may be wrong about that. But they are warranted for 10 years. I don't know if it covers capsule and fracture, but it definitely covers, rupture in the first 10 years. But, Madeline, thanks so much for calling. And we are hitting the end of this first hour. And so we're going to need to take a break soon, and we want to make sure that you can, once again, we're pushing the SiriusXM app, and if you want to listen to this, at other times or whatever, you can just get the app at SiriusXM.com/app. We are going to have open phone lines. Our phone number is again 877-NYDOT, 877-698-3627, and we will be happy to take your calls. We're going to take a little break.
Thursdays, Jonathan Wakefield explores craft beer and pop culture. This week, Theo Hunter from Crown & Hobbs and Aaron Brooks, executive chef at Four Seasons Miami. Listen on Channel 132 or anytime with the SiriusXM app.
Wednesday on Dr. Radio at 10 a.m. East, our pediatricians discuss the safety and efficacy of the recently approved COVID vaccines for children and teens. At noon, otolaryngologist Dr. Sean McMenemy explains how speech-language pathologists can help with some of the long COVID symptoms, including cognitive issues and swallowing difficulties. At 6 p.m. East, bladder cancer is the fourth most common cancer in men. Learn about the risks, symptoms, and advances in treatment during the Men's Health Show. That's just some of what's happening Wednesday on SiriusXM Dr. Radio. This is an important message from the CDC on managing stress. Don't underestimate the impact your own stress may have on your child. Children and teens may have a stronger response to crisis. Signs of stress may include sleep disruption, increased social isolation, self-harm, or use of drugs or alcohol. If you're concerned your child is showing signs of severe depression or having thoughts of suicide, get help immediately. Reach out to your healthcare provider or call 911.
What a Joke is the name of the show? What a Joke. It's Papa and Fortune.
Comedians Tom Papa and Fortune Feimster hang out with all their comedian friends on Netflix's A Joke Radio.
Yeah. You guys are like two of my favorite comedians of all time.
I love you.
Guess what? What? It's popular.
What a Joke with Papa and Fortune. Weekdays at 10 a.m. East and on demand. Plus, wall-to-wall comedy clips from Netflix's exclusive and unparalleled library of top comedy specials. Netflix is A Joke Radio, SiriusXM 93.
It's not just a race. It's an American tradition. Start your engine. The Indianapolis Sports Audio Channel 211 with extended coverage on IndyCar Nation Channel 205, the Sirius XM app, free for most subscribers.
Coronavirus. What you need to know now. This is a global pandemic, and it has to be a global response. So even though we are very successful in rolling out and getting into people's homes vaccines, if there's still a lot of infection in the global community, which gives it the opportunity to evolve into variants, we will always be vulnerable.
Hear the latest updates about COVID-19 on Sirius XM Doctor Radio.
Get facts, not fear. Dr. Radio brings you everything you need to know about the coronavirus crisis. Sirius XM 110.
You're listening to Plastic Surgery on Doctor Radio.
Welcome back to the Plastic Surgery Show. My name is Noah Carpenter. We are live from our studio in the luxurious lobby of the NYU Langone Medical Center. You are listening to Dr. Radio on Sirius XM, Channel 110. Our guest, Ashley Malfi, plastic surgeon in Rochester, New York. Ashley, welcome back.
Thanks, Nolan. Second hour here. I'm excited to hear what the callers have to say.
Yeah, we'll see what they say, and hopefully we'll have answers, maybe even correct answers. That would even be better. Our phone number, 1-877-NYU-DOCS. That's 877-698-3627. Call us about, aesthetic surgery anywhere, whatever you're thinking about. I think we'll go to our first caller, waiting a very long time. Amy from California. Amy, you're on the Plastic Surgery Show.
Hi there. Thanks so much for taking my call. I just have some questions about lip enhancement surgery. Whether you feel this is a effective procedure, what's the recovery like, are there potential side effects or complications, and how invasive is the procedure in terms of can it be done in a outpatient or physician office setting?
So what is your goal, Amy? I'm trying to figure that out. Is it to shorten your lip and just lift it? I'm just trying to explain, what are you trying to achieve with this?
Well, I think with aging, your lip and that space between your nose and your mouth seems to elongate, and you kind of also have a bit of a downturn towards your mouth, and your lips actually kind of shrink, it seems, and not to have those Hollywood big lips or anything like that, but I'm curious if this would be, kind of more aesthetically pleasing surgery as opposed to fillers and that kind of thing.
Ashley, what do you think?
I mean, it's more of a permanent fix, Amy, and it's certainly something that's trending and that we're seeing a lot more of. In general, we're seeing a lot of lip filler, and when people think of lip filler, they think of all the bad lip filler. What you don't know is all the people you're walking around with and seeing at the grocery store who, have aging lips just like you do and have filler in there tastefully, and they actually have beautiful looking natural lips. So the filler doesn't have to be unnatural, and I think that's why some people get kind of scared of filler, is because they just know it's the bad job. But if you've had filler and you've had repeat filler, and it seems like you want more of a permanent fix, then a little skin excision right under the nose, is that what you're talking about, Amy? Has become a really popular sort of trend.
Yeah.
So what, exactly. So it's not a very invasive surgery. I think it's definitely something that a plastic surgeon, a board-certified plastic surgeon, can do in an office setting. But they just take out a little wedge of skin, essentially, and hide that incision just along the groove under the nose. And that shortens the distance from the nostrils down to the lip and just gives you a little bit of a lift. It's more permanent. And so I think as long as it's tastefully done, it's a great permanent solution to your problem. I think it's probably a little less effective on the corners of your mouth and is going to be more effective centrally, since the excision is only under the nose. It's going to more so affect the central portion of your lip. But yeah, it's a great little procedure and not a lot of downtime. Risk being that it's a little bit asymmetric, or it's not as much of a result as you wanted, swelling, bruising, all the normal stuff. But as far as plastic surgery goes, this is a minor thing, and I think that's why it's gaining so much popularity, because it's kind of a lot of bang for your buck and much more permanent than just doing fillers every 6 months.
What do you think, Amy?
Thank you.
All right, thanks very much. We're going to move on to Ari from Washington, D.C. Ari, you're on the Plastic Surgery Show.
Hello, how are you?
Good, how are you?
I am well, thank you. So I had lipo in the States in 2015. Then I did it in the Dominican 2016 and again in 2019. My problem is I keep eating. But and I always have these, at one point I'll realize exercising is not as bad as the surgery recovery. But my stomach, since it's been lipoed a few times, this past time has a lot of scar tissue, and I did some of the lymphatic massages and the follow-up surgical massages. This past time, I did the first 2 times, and my stomach will sometimes be sore or lumpy, and I've been told that it can be fixed. It's the fibrosis or scar tissue that they can fix, and I guess I did schedule to go for surgery in Florida in July, but I'm just curious, how does it get fixed? Because I haven't even seen that doctor. They tell you to send photos, and I did that, but my regular doctor here has felt my stomach.
So give us a little history. Have you had kids, Ari?
Never.
And what is your height and weight and things like that?
5'2". I am 170, so I'm curvy. I did the lipo, a 360 lipo and a BBL. So people joke and say that it's all in my butt at this point, the weight. But it's just my stomach area that is sore.
Do you have looseness in your stomach, or is it just scarring from, it sounds like you were kind of almost over liposuction. They were looking for fat for your BBL, and they oversuctioned you. I have taken care of patients with this problem who are oversuction, because the oversuction in the abdomen really shows, because when you bend a little bit or bend down, really the irregularities really show. And I have done tummy tucks on some of these people where I've been able to go in there, raise up the skin flap, and then from the underneath, I've been able to kind of smooth things out, and also by pulling down and taking out some skin. You can't necessarily make it better, but you can make it a lot better. You can't make it perfect, let's put it that way, but you can make it better. But you haven't had kids, so that's, I don't know how much laxity you're going to have in terms of a full tummy tuck.
Okay, yeah, I've been told maybe a mini tummy tuck. So, and I guess because I don't have a lot of skin, I've always had a pretty flat stomach. My head has been more in my arms, my hips, and now after the lipo, it tends to go to my arms and my legs. Well, but I guess my stomach is, if I don't have a ton of fat there and a little bit below my belly button, right before the pubic area, is where it just gets lumpy looking. And
you can get that. The belly's a tricky area to lipo. You can get that, and you have to be very careful about that. And but I have on occasion been able to kind of prove that. Ashley, what do you think?
I think it's a hard problem to fix, Amy. I think, having more liposuction is probably not the answer, because there's probably some areas that are just really, really thin, and then the skin is scarring down to your abdomen and creating kind of those weird little divots and dimples. Can you break up the scar tissue without doing a tummy tuck? You can. I don't think it will be terribly successful. like Dr. Clark was saying, I think, a tummy tuck is usually the best answer for patients who unfortunately have this problem, because we are able to cut through some of that scar tissue, remove some of the skin that's just uneven or too thin in spots. And, I think that there's plenty of excellent plastic surgeons, if you travel to these different areas, but I would be very, very leery of medical tourism and make sure that, that the person that you're seeing is actually a board-certified plastic surgeon. They will often falsely advertise that they're board-certified, but if you look a little bit deeper, they're not actually plastic surgery trained the way that we are. And when you are, dealing with a difficult problem like this, I think, now more than ever, so important that you know who you're going to.
How do you verify if they're board certified? I mean, I on real self, but I don't know if necessarily that's accurate.
You can go on the American Board of Plastic Surgery website and look them up. And it's pretty simple. And that's the one legitimate board, and you just go on the American Board of Plastic Surgery. It's pretty simple. It's in Philadelphia, and you can just look up, and maybe Dr. Malfi can tell us, like, what she had to go through, to get board certified, like all the steps. You don't have to start with nursing school, but you can kind of after college, let's say.
So you go to college, you're pre-med, you apply to medical school, you do 4 years of medical school, and then to get into a plastic surgery residency, there's sort of 2 ways to do it. You can, right away in medical school that you want to be a plastic surgeon, and that's how I was. Then you match into plastic surgery as a residency, which is a 6-year training. And that's super, super competitive to get into. And then the other option is that you train as a general surgeon first, and then you do a tack-on 3-year residency in plastic surgery. So then you're doing 8 years of actual surgical, hands-on surgical training as a physician. And then beyond that, if you want to subspecialize, then you can do another year of a fellowship. So, we're talking 14, 16, 18 years of training.
After college.
So it's expensive, but it's expensive for a reason. And so, I think that the ASPS Nolan also has assigned a board certified plastic surgeon.
That too. Yeah. ASPS also. I mean, that's nobody, you can't be an ASPS if you're not certified by the American Board of Plastic Surgery. So that too. I mean, those two are two great ways to find somebody board certified. If they're not in either of them, then I would find somebody else.
Absolutely. And just,
But then after that, you did all that training, you finally got done, finally, went into practice, and then you went out and you were in Rochester, University of Rochester. And then what you have to do?
So to actually become board certified after you graduate from your training, there's sort of 2 parts of the examination. So the first part is a written board examination where you study for, honestly, every year of your training, and then half a year to study for that exam, and you have to pass your written exam. And then your entire first year of practice, we collect all of the cases that we do and submit those to the American Board of Plastic Surgery, and then they will look back at your cases and allow you to sit for your exam if you are showing that you are a diverse surgeon, you're doing enough surgery and enough different types of surgery. And then you have an oral examination, which has 2 parts. They actually go through some of your own cases that you've done and ask you, why did you do this, and what would you do differently, and what if this happened? And so they take you down those scenarios. And then they also give you a whole bunch of unknown cases where they'll show you a photo and they'll say, this is Amy, she's had liposuction 3 times, this is her problem, how would you fix it? And so you solve at least 12 unknown problems like that, just to show that you're a safe and qualified surgeon. And so those are super, super strenuous exams, and probably the exam I'm the most proud of ever doing well on, right, Nolan? You too?
Yeah, no, I mean, I'll actually make the exam.
Perfect.
So it's, No, it's a very rigorous process, and the idea is to to put out safe, ethical plastic surgeons, and So anyway, I mean, we didn't want to get into too much of this, but so I think it's important. You've traveled around a little bit and done some medical tourism, and now, do you know about the surgeon in Florida you're thinking about going to, Ari?
I did research on Real Self, and you can tell me if that's not a good site, but that's where I found him, and he certainly had high reviews. Over, I think it was like 1,000 reviews or something posted for us. But he did say ASPS. I think he did have ASPS, I think is what you just said. I think I remember seeing
ASPS, ASAPS, the Aesthetic Society. If you're in those, then you're board certified. I mean, I think that, Real Self, it's fine. It's a good source of information and everything, but it is slightly self-serving. It's not objective or anything, and I think it's a way to
you don't have to be a core doctor to be on there anymore.
No.
So you don't have to be a plastic surgeon. You can be a family medicine doctor who decides that they want to inject Botox, and you can create a Real Self profile if you pay for it. So, it's a great site. It's great for patients to ask questions. It's a great place to put reviews, but I wouldn't consider it, verification of anyone's credentialing or education.
Yeah, there's no objectivity there. It's basically whatever people want to put on there. Anyway, Ari, have we helped you at all?
You are, and you've given me some stuff to go research, so I thank you.
All right.
We're proud of you. Thanks.
All right, good job. Our phone number, 1-877-NYU-DOCS. That's 877-698-3627. We're, taking your questions. Give us a call. We are going to move now to Lisa from California. Lisa, you're on the Plastic Surgery Show.
Hello.
Hello.
Hello. Hi, how are you?
Good, how are you?
Doing good. My question is, I have very shut-in lower eyes, very dark circle. I'm 59 years old, and I don't know if there's a plastic surgery procedure that would help me with that, get more volume.
Have you had surgery before? Have you had your eyes done before? Anything done before? Or this is just how they are?
This is how they are.
I mean, I think that, there's a lot of different things you can do. You can do fillers. You can do fat grafting. There's a lot of things that can be done to kind of fill out your eyes. It's a little bit tricky because it's a delicate area, and anything that's not absolutely perfect is going to show. But, you definitely can do things to improve your eyes.
Oh, okay. That was my question. I didn't know there was help for that.
There's help. Ashley, any ideas on this?
Yeah, I would definitely find a board-certified plastic surgeon in your area. There's surgical and non-surgical options, So sometimes patients will start with some of the less invasive things like fillers, and that can help to kind of soften that deep groove that you have under your eye, and that can last 6 months to a year. So that's kind of a nice fix. And then if you're looking for something more permanent, it's also very straightforward surgery to recover from. So have you started looking for doctors, Lisa? Okay. Well, thank you very much. Now, what about an implant? Could I have an implant?
Doesn't work in that. It doesn't work in the eyes. It just doesn't look good. It needs either a filler or some fat or something like that. But putting an implant in doesn't work. It's too delicate an area for an implant.
Okay. Thank you very much.
All right, Lisa, thanks so much for calling. Our phone number, once again, 1-877-NYU-DOCS. That's 877-698-3627. So, Ashley, in your younger patients, what are you seeing? What are they coming... forget about the surgery. Let's talk about, the younger patients for their facial appearance. What are they coming in for? How young are people coming in for Botox and fillers and things like that?
Yeah, there's definitely a new trend now towards what they're calling preventative Botox. And it's this whole sort of movement towards, health and wellness and aging gracefully in this generation, this younger generation, 20s, really embracing that. So essentially, they're considering it preventative medicine. They're injecting Botox. And Botox just freezes those local muscles and prevents you from making the wrinkles in the skin. And they're doing it at a younger age so that they never make the wrinkles. So, I think it's kind of brilliant. And it's allowing them to treat it, just a couple times a year and never get those deep, hard wrinkles that are so hard to chase when we see patients who are, kind of too little, too late. Are you seeing that trend in the city too?
I think there are. I mean, it's not really I do so much, but I do some Botox injectables, but it's not kind of my practice, emphasizes, but, I hate to say it, I have like a 23-year-old daughter, and not that she's done it, she hasn't done anything, but, some of her friends are starting to ask me about it, so, I mean, I think that tells you kind of where this is going, so it's, I think, people in their 20s, I mean, I have done it, people in their 20s, it's funny, it's usually been the kids of my patients. I do Botox, I did a face, left their eyes under the mom, and all of a sudden, my daughter's 28, 29, so it's getting earlier. It's mostly Botox, it's usually not fillers occasionally, it's Botox.
Lips, a lot of the younger girls are getting lips. I see a lot of girls who are college age who save their money and that's what they really want is just a fuller lip. But the Botox is great. Any neuromodulator, I like Dysport and, there's a variety of brands out there that all do the same thing. But you don't have to do it as frequently and they're just doing it a couple times a year and it's just allowing them to have a little less movement up there to prevent some of those deeper wrinkles, This is also that generation that's really into skincare and, getting facials and getting their eyelashes done. And so I think that, taking care of their skin in this way and preventing the wrinkle formation is just kind of a natural extension of all that.
Yeah, it starts super early, and they're doing all sorts of stuff. Like in my generation, nobody knew at least I didn't know about it. But today, it's just like, in between social media and just everything that's out there, there's just such tremendous access to information that, people have all that information right where you are. So they're just, it's not just like a New York thing or a California thing. It's kind of everywhere. The lips are a big thing. I mean, I don't do much of it, but it's a huge thing. And I think that a lot of young people, very young people, like late teenagers, early 20s are doing lips.
Yeah, and the younger girls want the fuller lips, but we see everyone who wants lip injections, even in the aging phase, just adding a little bit of volume or even just some structure to the lip, which is what we lose as we age. Is lip filler goes a long way, and with masks, we kind of joke that it's perfect because it's totally socially acceptable to wear a mask for a week, and you can get through the bruising and the swelling and all that, and no one really notices. And then when you're ready to take your mask off, you have the lips of your dreams. So it's definitely a trend, even when people were wearing masks, that they wanted the lips that look good on their Zoom camera. So we're seeing a lot of that.
It's funny you mention that because the mask has really helped on, like with like the lower eyelids. If you're wearing a mask a little higher and a pair of glasses, nobody can tell. There's just no way they can't tell. And you can just go about your business, or even doing a facelift. You put the mask on. They don't beat up. You're wearing a mask, and you get one of those masks. And on a woman's face, which doesn't tend to be that big, one of those like masks that's like a little bit bigger, you can't tell anything. I mean, it helped hide it. And maybe 10% of people wore masks as a relic of SARS. I used to think it might have been some pollution or something.
I think there's pollution there too, yeah.
I think you're going to have people here wearing masks, and it's going to be acceptable because right now most people are wearing masks. So I think you're going to see a lot more of that, and I think it'll be a lot easier to cover up for plastic surgery. Well, we have a bunch of callers again, so I'm going to go to Diana from New York. Diana, you're on the Plastic Surgery Show.
Hi, thank you for taking my call.
You are welcome. What's going on?
I Hi, Diana. Hi. So I wanted to reach out. So I have had some trauma. I had a motor vehicle accident in 2010. I broke my left condyle. And I've noticed, especially in the last couple of years, quite a bit of asymmetry and changes in my jawline, more so than before, which, I'm assuming is probably related to the accident, the way...
And it'll come right up. Can you just Google that?
Perfect.
I think I would see him, because he's literally the, he does, things like face transplants, but, that's not that often. I mean, I think, but his specialty, he trained in Maryland shock trauma, and his specialty has really been facial traumatic injuries. And, from, what could be not, minor, yours might be minor, it's a major, but that's what he does. So I think, he's a good place to start with this.
Okay, great. I appreciate that.
All right, Diana, we're going to move on to John from Connecticut. John, you're on the Plastic Surgery Show.
Yes, hi, doctor. Thank you for taking my call today.
Yeah, we hear
you.
We got you.
Great. I have a torn bicep tendon, my left bicep tendon, and about 7 or 8 years post-trauma. And basically what happened is that my bicep tore, and she went up my shoulder like a yo-yo. And obviously the small tendon's not available there to pull it back down again because it got absorbed into the surrounding tissue. So is there anything that you can do, or anybody you can help me to put it back so it looks normal?
It's not really what we do. Actually, I don't think you do this.
I don't do hands anymore, no.
I mean, I think...
Yeah.